every debate, and today is a very special day. We have a great surgeon with us as eminent guest speaker and commentator, Dr. Basem Ishak. He is a young professor and chief of spine at the eminent University of Heidelberg in Germany. And I'll introduce him in greater detail later, but we're heavily conflicted because this colleague spent a year with us. He's a former AO Spine Fellow and former fellow at our institution. And he's really done an amazing job in his young career at pushing and looking carefully at boundaries in spine surgery, something that when we were younger, surgeons like myself did not anticipate one day being a main theme in spine care. The spine is an organ system that is set to fail. I hope that all of you have tuned into SSF also for other programs. Last night we had a program in our quarterly spine arthroplasty session, and please go into the library to take a look at that. It's pretty amazing. We had several hundred people participate where we looked at failures of certain distal implants, so please check that out. Also an announcement, April 30th, we have the first ever guided interventional spine procedures course, which offers, again, plenty of opportunities to look at new developments, but also controversies in the field of interventional spine care. We have a global audience today, and it's a particular pleasure to also introduce Professor Tariq Sohail from Lahore and his department, and we'll have a case presentation by one of his young doctors. We've also prepared some cases, and we're eager to hear our visiting professor, Dr. Basem Ishak, in terms of his commentary, and then his lecture a little bit later about surgery, spine surgery, and the aging. Tariq, are you live and available?
Yes, we are available. Yeah.
Great. So we can hear you. Can you just introduce yourself briefly and then your colleague, and maybe we can proceed with an interesting case presentation from Lahore.
We lost Dr. Mahmoud for the beginning. So okay. We should start with the Swedish fellows.
So we will start, we'll change programs. We've had an interruption of our live feed to Pakistan. So one of our fantastic young fellows will take the lead. Coming in a blue ski jacket, Dr. Nathan Pratt, and he's going to show one of our cases for discussion and debate.
All right. Yeah. I think there is some problem with the communication.
No problem. We can wait.
Sure. Thank you.
Okay, good morning, everybody. My name is Nathan Pratt, one of the spine fellows here at Swedish. I am a neurosurgeon. So, I'll give you a case here. 74, this is a patient of a 3-year-long story here. 74 years old, initially presents with diagnosis of OPLL and ankylosis with neck pain. That's better. Neck pain and a cervical spine fracture after a ground level fall at home. He had no weakness or numbness, no bowel or bladder symptoms, no neurologic symptoms at all, just significant neck pain. Past medical history is sort of unremarkable for him. And physically, he was neurologically intact at that time. He came in with a fracture through this sort of ankylosed segment at C4-5 with OPLL posteriorly. And ankylosis extending throughout the entire cervical spine. This is MRI at that time as well, showing no areas of significant compression. So this was, again, 3 years ago. At that point, the patient was maintained in Miami J collar, discharged to home with home health and physical therapy, followed up in June, stable neurologically, no new complaints. Neck pain was reduced. You can see starting to bridge in August by October, improving even more, and then by December, this is pretty much healed up. He then kind of was lost to follow-up. His fracture had healed. He didn't follow up with us for quite some time. Next time we saw him was March of this year. He was transferred from an outside hospital. He came in with a new C-spine fractures, which we'll look at here in just a sec. After a fall forward onto his face at home, patient had been having multiple syncopal events, reports that he lost consciousness, fell forward, does not remember the event at all. No neurologic symptoms at all, and no interval changes in his medical condition except this sort of syncope of indeterminate etiology. Physically, he has multiple abrasions on his face bilaterally, very clear that he fell. but still no focal deficits, no focal signs of myelopathy. CT spine, much more significant this time, a type 1C1 fracture, bilateral posterior arch fracture, which we'll see on the next slide. Type 2A dens fracture, angulation of the dens with fracture kind of through the base of the dens, kind of headed toward a type 3, but definitely unstable type 2. And then a hyperextension fracture at C5-6, the level below where he had that hyperextension fracture before, which was much less notable in his prior imaging. And this encompasses the entire vertebral body of C6. So here are the slides here. You can't really see the other side of that posterior arch of C1, but he's fractured through both of those. You can see the dens fracture comes through the bottom of the dens toward the vertebral body, still 2A rather than being a 3. It really does involve the base of the dens. And then the other fracture, this is the C5-6 level, just to show there's no posterior element fracture at that level. So our plan for him, he was taking the OR for stabilization. Oh, yeah, back.
Baz, are you live, Baz?
Yes, I am.
So ankylosing spondylitis, go back for a second, Nathan, and show us that initial picture. So ankylosing spondylitis, this has become a curse of our clinical existence in the US, as you may remember from your time here in Seattle. And this is somewhat paired with aging and obviously a lot of comorbidities. Is this the same problem that you've seen around the world and specifically in Germany?
Yes, absolutely. It's the same thing we've seen in the US. Absolutely.
And this is obviously something that fulfills us with horror because these are frequently unstable injuries and they have a high likelihood of severe secondary injuries. If you looked at this initial injury there, was this something that you would have agreed with treating non-surgically?
I would definitely agree with doing that non-surgically, but I probably would have done surgical treatment, honestly.
And like what?
Not because it's unstable, not because he has neurological impairment, because my experience by like bracing those or treating with a collar is that further dislocation occurs like after 3 or 6 months. So therefore, we decided to treat them surgically from the beginning.
Mm-hmm. And so what would you have done? Anterior or multilevel posterior surgery?
No, just posterior. You often often have a gap. Anterior, you leave the gap, that's fine, but you have to be aggressive with the construction. So at least 3 above and 3 below, right?
Yeah. But this patient did well from this, Nathan, after the initial injury.
Yeah, this is 6-7 months after the initial injury right here. See the 4-5 space healed very well.
One thing that I'd like to ask you, Nathan, is these patients frequently have significant spinal deformities, which are then frozen from the underlying disease process in a pretty bad position. What do you know about his overall posture? Was the center of gravity off, or was that kind of balanced?
He was, we never got a full-length standing Scoli film on him because he went to the OR the day that we saw him, and he was seen by one of our former partners, and I don't think he ever worked that up. He probably had a little bit of positive sagittal balance, but I don't think it was significant, and his cervical spine didn't have I mean, obviously he's got a straight neck, right? But the deformity was not so severe that, you know, you would think you need to really try to correct that.
And Dr. Ishak, we talked about taking the patient to the operating room. If this patient has a significant forward tilt in general, would you try to extend the patient backwards a little bit in terms of extending the patient to improve the sagittal balance? Or do you want to just fix him where that deformity is, best possible fracture fixation, and treat any deformity later on an elective basis?
Yes, I would not overcorrect those patients. I mean, we did this in the past and had bad experience. To improve like the balance is not a good idea, actually. So we keep them. I mean, if they have severe kyphosis, we probably just correct a little bit, but do not do an overcorrection and just fix them as it is. And if we want to address the deformity, we take them later on to the OR, but we never did this actually. So no overcorrection.
All right. Now tell us what you did here, Nathan.
Right. So we took the patient to the OR for a C1 to T3 posterior cervical fusion without decompression. We had the prior imaging showing they had no areas of focal compression and no neurologic symptoms. This surgery went very well, very uneventful. Patient did great post-operatively, was discharged to a SNF on post-op day 7 just due to problems with mobilization because of his neck pain, because of his syncopal episodes. I guess this is the part where you run into trouble dealing with just older patients in general. He came
and
back.
We got good realignment. Of
great. Yeah, it's great.
C2 fracture because it was posteriorly displaced too.
Yeah, I should have shown the CT as well. But yeah, the C2 fracture is aligned. I think you can kind of see it on the x-ray. Everything's lined up. He's not overextended at that 5-6 level, which is obviously one of the concerns as well. He's already got a big gap there. Having that closed down is really important in these AS patients. And all of that occurred on this or on the post-op film that we can see here. We don't have a full length an x-ray yet, but still a little tilted forward, but nothing outrageous there.
Quick check-in with Dr. Ishak. Any questions about this? Does this look like a reasonable construct to you? But obviously, every attempt was made by Dr. Skuin in this case to avoid the occiput. Do you agree with that?
Absolutely. I mean, the occiput is very important to not fuse the occiput if not necessary, especially in the elderly. If you do it too anteriorly, they fall down, they have swallowing issues, right? And the same as if you put them or fuse them like with the head too much posteriorly, right?
Yeah, sorry, Dr. Sohail from Lahore.
Yep. Since the bone was very bad to begin with, was there any problem in securing this fixation in a long construct?
Let's ask the
surgeon. Would you be concerned about it and you start any medication?
No, I mean, it was kind of the typical, looks hard, but very soft bone, not great bone, but we got decent fixation.
And what about C1? Was that good fixation?
Yeah.
Lateral masses, they're usually pretty good. All right, Nathan, carry on.
I'll wrap this a little bit here. This is the part where, you know, dealing with older patients becomes an issue. He basically came back to the ER, had another fall while he was standing and found down at home by a friend, evaluated for a possible stroke. That workup was all negative. He was found to have sepsis and mitral valve endocarditis, admitted for the management of his sepsis. He has a postoperative fluid collection on his MRI. Neurologically, he remained stable. Clinically, from a spine standpoint, we did not feel that collection, even though it looks pretty significant here, was you know, something that needed surgical treatment. It doesn't really enhance on the post-GAD, and the patient's incision is well healed. Looks like the tissues are fine. So he's being treated for that. But obviously, anytime there's a patient who's older like this, whose mobilization is poor, who's already got some sort of underlying either cardiac or vascular issue leading to his syncope or neural issue, unclear what the etiology is there, higher risk for having some sort of a readmission bounce back, kind of like this. So.
All right. And what's happened further?
He's still admitted to the hospital. They're trying to decide if they want to replace his mitral valve or not. Probably not. They're treating him with antibiotics right now. He's inpatient today.
So, Baz, when you see a patient with a type 2 odontoid fracture, and this patient is in his, what's the age?
Late
77.
77.
Now 70.
With substantial comorbidities, what's their 1-year chance of survival in Germany?
With surgical or without surgical treatment?
Give us a rundown for both.
I mean, I later on will present a study of elderly patients with odontoid type 2 fractures with a 3 to 5 year follow-up, actually, with good results. So survival rate is 100% actually in Germany. If you do not treat them surgically, we have seen like problems at the skilled nursing facilities or nurse homes where the patients were treated with a collar, and the nurses said, okay, this guy has a broken neck, so leave him in his bed, don't mobilize too much. And this was like a problem, and they developed pneumonia and died due to the pneumonia or other things which are associated with no mobilization. So worse outcomes if you treated the patients not surgically.
Great. We're looking forward to hearing your presentation.
It may worsen out. It may worsen out if it is treated conservatively. But in the cases, it actually the level of the injury which decides the outcome. If the patient is having spinal cord injury at very first instance, I have seen the cases where the patients presenting ankylosing spondylitis with their cervical injury at the level of C3, C4, or they have bad results. But in the cases where we find the cases in the thoracolumbar region, they are quite good results in such cases. So actually, in the ankylosing spondylitis, actually the thing is level is much more important than any other thing.
Great points. So let's have Dr. Favert come here and present another case from Swedish right now, and we'll get ready later to have Dr. Ahmad present his case. So this is Dr. Favert, Yev. And I think we're going to get older and older in our patients. Is that right, Yev?
Yes, we're escalating. We're escalating here. All right. Good morning, everyone. I'm Yev Favert, one of the neurosurgery spine fellows here at Swedish. Present another quick case. Our patient is an 83-year-old male who's presenting after about 3 to 4 months of bilateral upper extremity weakness and paresthesia. His symptoms have been gradually progressive. He got worked up on an outpatient basis, and reportedly there was some C5-6 stenosis that was observed. He was conservatively managed with PO analgesia and steroids, and now he presents to clinic with failure of his management. Basically, his symptoms have been progressing despite the medications. He also now relates some minor complaints of poor balance. Systemically, this gentleman isn't too sick. He has some of the common problems you'd expect with an 83-year-old. He's got an enlarged prostate, some GERD, but no major illnesses. On physical exam, his strength is full except for 4 out of 5 in the right grip. Reflexes are normal except for a slightly positive Hoffman on the right side, and he complains of reduced sensation in bilateral upper extremities, kind of most focused on the 5-6 dermatome, with maybe a little bit below that as well. These are his FlexX scans, kind of the expected degenerative disease you'd expect to see in a gentleman this age, but otherwise, no major spondylolisthesis or anything. This is his CT, again, demonstrating degenerative disease with, probably the most degeneration at C5-6, and that horizontal cut, the axial is at approximately the 5-6 disc space. And then this is the MRI, again, demonstrating similar findings, and that axial cut is at the level of maximal stenosis, which again is at 5-6. So, we have an 83-year-old gentleman with these findings, and the question is continue and escalate conservative management, or consider operative intervention. And if you do consider operative intervention, then is the approach to pursue something more minimal versus more comprehensive intervention. And then the question being, even though the stenosis is really only significant at 5-6 right now, you can tell that the levels adjacent to that region are starting to degenerate pretty aggressively as well.
Okay, very common case, Yev. So go back to that MRI.
Yes.
So chronologic age again is what?
83.
Physiologic age, again, best gestalt.
Probably a little bit better, but maybe late 70s.
Cognitive function, fine, active, engaged, independent living.
Yeah, no major concerns.
Dr. Ishak, one of the problems we have with the elderly, and I think you're going to address that later, but just give us your survey thoughts, is how complex it is to try to assess the vivaciousness, the viability of elderly patients. There are very highly functioning late octogenarians and even nonagenarians, and there are people who in their 60s are highly decrepit and sick. How do you kind of get a handle on that?
Well, it's a great question. Of course, the first thing is such things, if you think of doing major surgery or complex surgery, talk to the patient and to his family too. So I think this is the most important thing we've learned in the past. And then we have to decide how to treat him, just doing anterior only or posterior only or combined procedure. And we actually published on that. I will present the study later on. But the most important thing is go to the patient, see the patient, what are his comorbidities, and what does the family think? I think these are the most important things for us before we start thinking of surgical treatment.
And one big problem that we always have in the US is the gambler's mentality, the thought that lay people and even so-called specialists don't have a healthy handle on statistics. Like if you tell somebody you have a 50-50 chance of survival of a given procedure, chances are most people, and that's the great work by Danny Kahneman and others, will think, oh, I'm going to be in the 50% winners. Is that something that you can somehow address and quantify to make statistics, especially adverse statistics, more transparent to patients and their families?
I mean, we can do that because we did a study actually on that, like multi-level cervical spondylosis with myelopathic symptoms. And what happens to the patient if we do like cervicothoracic fusion, like surgery crossing the cervical-thoracic junction? And we have data on that, and actually the survival for 1 year is 100%. So they will not die if you do surgery.
That's a great point. One other source of frustration of our service here, and we're also joined by Dr. Hart here and Dr. Squin and Dr. Abdul Jabbar is here, is how poorly myelopathy is detected in our US medical system. And you may remember that when you were here, Baz, it's really remarkable how many patients have myelopathy and significant myelopathy, even have been completely missed by our medical system. Is this the same in Germany? Do we have an insufficient medical system? Was there an insufficient attention to picking up myelopathy as in medical school teachings?
Yeah, I don't think it's a problem of the system. I think myelopathy is often difficult to diagnose. I mean, the patients come with gait issues. They have no neck pain, no arm pain, no numbness in the hands. So they had gait problems. So the first thing is, okay, it is a neurologic issue, or is it probably vascular? So we always have like late diagnosis, right? Because not all the patients who have gait issues or some numbness in the hands receive an MRI, but we see a delay too. But I think the people are not aware of myelopathy itself.
Okay, what would you do in this patient? So we have a relatively functional octogenarian with cervical problems, surgery, watch the patient more. This patient seems to be disabled, right, Yev?
Getting there, not terrible, but certainly headed in that direction. I think we're catching it relatively early.
So do you want to catch it early and intervene now, or do you want to wait for a year or so, Baz, and the patient that Yev is?
No. I personally would not wait. I see the symptoms, I see the images, I see the compression of the spinal cord. So I would recommend surgical treatment, because if we do not do that and just wait, this might deteriorate, right? And what we want to do if we treat myelopathy is not that the symptoms improve. It's the fact that it stays as it is and does not worsen. And this is the goal when treating myelopathy. So I always try to do minimal, like try probably anterior only. And if it's, of course, more than 3 levels, we have to think about a posterior approach with multi-level laminectomies and fusion. And then, of course, if we have people who love sagittal balance and alignment, and we know this has something to do with functional outcome and neck pain, so alignment is important, they also try to treat them combined. But I would not do it combined, either anterior only or posterior only.
Great. Okay, Yev, what was done and how did the patient do?
Yeah, absolutely. It's funny you mentioned the gambler's mentality. There's I think that's historic. There's a quote from some guy, World War II vet, who stormed Normandy, and I remember he says he was in the boat as they were storming the beach, and he said he looks around the guys in the boat with him. They were quoted an 80% chance of death, and he remembers thinking, "Man, I feel really bad for those other 80% of the guys." So let's storm the beaches here. So we did a focal intervention, C5-6 ACDF. The patient did really well. You know, in these older patients, you're a little bit concerned about swallowing difficulty, but that didn't happen here. He was discharged uneventfully post-op day 1 and referred to PT after about a month. Unfortunately, he returned 3 months later with persistent, maybe recurrent post-op pain. This was his MRI at the time, and the 5-6 level was decompressed, but now he's starting to degenerate at the level above. At this point, again, because the patient was relatively functional and otherwise doing well, and this is the CT, we proceeded with C3/7 LEMI fusion again after discussing the risks and benefits with the patient. He was discharged post-op day 3 to rehab after his drain output tapered.
Go back again one slide. So what's going on? What happened? What went wrong?
I mean, it looks like he's starting to slip a little bit at the.
There was an MRI. He actually fell, and it looks like he had a disc herniation at the level above. And so I don't know if you can see it there, but there was some cord signal change at C4-5. And then he had persistent radiculopathy. And just given this finding, we decided decompression, or I think I managed him for about 6 months without doing surgery. We decided to go from the back rather than go back in from the front. But you can see that's a pretty significant disc herniation.
Yeah, for sure. But yeah, subsequently he did well, and this was just a little while ago. We don't have major long-term follow-up.
So Baz, osteoporosis is a really big deal. Fall prevention is a really big deal. Should we routinely have DEXA scans, or should we routinely do CT-based bone density measurements and adapt our invasiveness of the surgery to what we see in bone density? And same question for balance. If patients have poor balance, should we do more bulletproof invasive constructs? Or what are your thoughts to try to balance osteoporosis and poor balance of patients?
Well, the first question, DEXA scan, I know it's the gold standard, but I do not believe in that. I mean, we have seen so many patients with a normal DEXA scan and high osteoporotic bone in the spine. So I don't know where the gap is, but I absolutely do not believe in the DEXA scans. I mean, a CT-based measurement is possible, but it's not standardized. So, or you have a center where you have a specialist with a CT and gives you some data about the bone, but in the end, you, like my personal experience, like in the OR, see the bone, feel the bone, and if it's osteoporotic, try bicortical, even for thoracic or lumbar pedicle screws, and if not, use cement. But we all know cement is highly dangerous, right? So, in terms of balance, we are pretty, defensive in terms of balancing. Very elderly patients and patients with osteoporosis. We've seen many screw loosenings. You try to reposition or to osteotomize patients because it was too much load. So we try to not balance those patients too much, actually.
So Hale, what do you think? Was this a surgeon error to just do an anti-cervical decompression fusion at one level? Should this have been a more extensive surgery from the start? Or was this just bad luck? What do you think?
Well, I think he's an elderly patient with a poor bone, and he had a 3-problem level. And I think 1 level is only symptomatic, and probably that was the level which is giving symptoms. I would have done from the posterior just single laminectomy alone. And because I think if you decompress it from the back, it probably would have relieved neurological symptoms and improve a status of mobilization. But going back, doing ACDF 1 level probably is not enough. If you have to do entirely, you have to have a 3-level ACDF. Then it's a long procedure. Then its own complications are there. So I would have done just 1 level laminectomy from the back, and maybe fusion at the same level through the lateral mass screws or through the pedicle screw, whichever is feasible. Because it's an elderly patient, the bone is poor, and the purchase on the lateral mass probably will not be that great unless you put a bicortical screws in the pedicle and the lateral mass.
Great. You have learning points for you?
I think kind of the things that we already touched on: good patient selection, possibility of escalating intervention if the first attempt doesn't work. It's a pretty straightforward case.
Rod, anything from your end? I mean, you've obviously handled this very nicely and immediately acted on the fall complication. What would you do differently?
I mean, honestly, maybe you've done, I think I agree with Tarek, maybe consider doing a Lamy from the back. That's the only other thing I can think of, really.
Yeah. But there's obviously always a fall risk. And this is something very frustrating because, again, in our general medical care system, falls are one of the leading causes of death in elderly patients. And it's an under-recognized cause of death. And it's perhaps not avoidable, but it could be lessened by more dedicated and focused mobilization focus. Jerry Robinson, last case from Swedish before we switch to Lahore for our case. This is Dr. Jerry Robinson, and he has selected the oldest patient from today.
Physiologically oldest.
Okay.
So my name is Jerry Robinson. I'm one of the ortho spine fellows here. Sorry for the lengthy description, but basically a 72-year-old female with severe osteoporosis, T-score of basically -5, diabetes, vitamin D deficiency, 5 months of low back pain after a syncopal fall 5 months ago, had a stable compression fracture at that time, but now feels like they're leaning forward. They required a walker for transfers, essentially in a wheelchair now, unable to get out of the home. Has low back pain that radiates into their buttocks and thighs with weakness in the ankles. They do have a neurogenic bladder that now is requiring a Foley with numbness and tingling, and has been wearing a brace without improvement. So here you can see the neurologic exam, weakness in the lower extremities. Here you can see the initial injury 5 months ago and 5 months post-injury. So you can see air within the vertebral body with severe collapse and retropulsion of this fracture into the spinal canal at L1.
And then there's a spinal stenosis at 4 or 5 also, just end-stage disc degeneration.
Correct. And there's a 4 or 5 spondy there that's mobile on flexion extension. Here's full-length radiographs. You can see pretty poor alignment and very poor bone quality with their severe osteoporosis.
So Baz, putting you on the spot, we talked about osteoporosis. Here's your osteoporosis. This is obviously terrible osteoporosis, and we don't have the luxury to really optimize bone health. This patient is in acute and significant distress and has...
They're in a wheelchair now.
Is basically wheelchair bound, still neurologically preserved function, repeat bowel bladder control.
Neurogenic bladder now requiring a Foley. And this has been declining over 5 months.
So 5-month period of decline. Posterior soft tissues are still intact, so there's no decubital ulcers. Baz, what do you say we should do here? I mean, this is obviously a terrible constellation of problems and a vulnerable bone, and there's spinal stenosis at 4 or 5 also. So do we try to solve it all, or do we just say, sorry, this is too bad?
I mean, well, it's a tough case, right? I mean, the stenosis or L4-5, we will say it's since years, right? So it's not the main focus now. The main focus is now the unstable fracture, right? With posterior displacement, and we have to deal with a severe osteoporosis, right? And it's not easy. So the thing is, it's L1. So I personally, we would recommend doing surgery, right? So what I would do is like 2 below and 3 above, right? Because the 12 one is no rib, right? Not really a rib. So we have at least like 2 fixed ones. So I would go like, what is it? Yeah, T10 to L3. The question is, we have high osteoporosis, so we try to aim with the thickest screw possible. I mean, we would do it navigated, so we can measure the screw thickness. If we feel the screw has grip and it's fine, I would leave it. If I feel it's very soft, and even with a thick screw, and even with placing the screw bicortically, we don't have a real fixation, I probably would go for cement. And just posterior only, and then we see how the patient's doing.
And would you do this just around the fracture site, or would you do this around L4-5 also, where the patient has a pretty significant looking stenosis?
I mean, I would do the first procedure because we try to keep the surgical time as low as possible. Because if we want to decompress L4-5, we probably would do it just minimally invasive and not fuse it, but it's too much time. So we try to fix the unstable fracture to stabilize that and to see how the patient's doing. If the patient's doing fine and has pain, which is related to the stenosis, we still can think of doing the stenosis later on. So this would be our idea.
All right. Sohail. Dr. Sohail, Tariq.
I think osteoporosis to me is a big issue in this patient. She has a retropulse fragment which causing pain along with the local kyphosis. I don't know. It's a very difficult. If anyone have experience using anti-clastic drug apart from teriparatide, which is osteoplastic, will take some time to be active. So is the other drug. And do you have any experience with denosumab that it takes care of the osteoclastic activity, and you can combine it with teriparatide so that you can have a sort of rejuvenation of the bone metabolism or bone equilibrium, and has some bone formation over a period of time. But immediate problem will be to stabilize it. I don't know. I have tried in osteoporotic patient with the cements. It's not very happy situation with the cement. Even if you use penetrated screws or you use any cement injected into the body and the pedicle, it's not a very good situation. They tend to pull out subsequently, and they create much more difficult problem to sort out. I don't know, it's a difficult situation. But having said that, well, if we fix it, we'll fix it, the fracture fragment, and I'll put a percutaneous screws in the L4-5 so that you don't wait for the symptom to be reevaluated. I'll just go in a single go it, and you had to go a little more than sort of above the D6, D8, and you have to come to something like a D4 or D5, 6 area so that she doesn't develop any PJK.
Yeah, Dr. Robinson, what were you going to say?
Yeah, so the problem with this patient is they're acutely getting worse, and they have active vitamin D deficiency and a bone health of a -5 on a DEXA. So you're kind of, you don't have good chance to optimize this. The question is, we've already had someone say they would go all posterior and then see how the patient did. Or, I mean, I think it's kind of tough to say what you do. Do you do a corpectomy and try to reestablish the anterior column because you have anterior column collapse and retropulsion? So, and it seems like a lot of the problems the patient is having is from that stenosis. So I can go ahead and go forward with what we did if you'd like.
Go back to the fracture one more time. Baz, Dr. Ishak. AO, I'm obviously, we are both, all of us, I think, Dr. Sohail is the same in our group here, are very passionate AO efforts at classifying fractures. When I look at this burst fracture, does the conventional AO system help us understand and describe this injury, either an A3 or an A4, or do we need something more and better to kind of describe the desperation of this fracture?
Again, I missed some part of the question. So, yeah, I mean,
is
you hear me?
AO enough? Is the AO classification enough to describe this burst fracture?
Absolutely. I mean, it's an A4 fracture, I would say, but we still have the T-leaks, and I strongly believe this is a T-leaks above 4. So we have two, in my opinion, good classifications. So,
Ishak, I think
the only modifier I might add is that this patient does have air in the vertebral body and has AVN. So maybe more of a push you one way or the other for healing potential. So this might be Kumel's disease of L1. So that's hard to tell how the AO classification would fit in with that.
This is a really big difference, I think, Jerry. Thanks for pointing that out, because air in a vertebral body implies vertebral osteonecrosis, implies that this is not a normal physiologic healing pattern anymore. This bone is actually dead and getting resorbed and will resorb in an ongoing fashion. So normal healing cannot be expected. At the same token, simple things like injecting cement into this are probably hopeless at this point in time. Tell us what we did so we can move forward.
Yeah, so, excuse me. Hello.
Yes.
PCN is actually not only based upon the morphology of the fracture.
I'm sorry, you're breaking up.
AO classification. We should always consider the modifier, and it always we have to keep it in mind whenever we have a fracture. It will over the time, even if a fracture is A2 on the presentation, but over the time it will behave like an A4 fracture. So yes. The thing is, it's not only the morphology of the fracture. Osteoporosis is a big modifier, and we should always keep in mind while treating such patients.
Great point. Fractures can evolve. Go ahead, Jerry.
So we actually decided to take care of all the problems at once, T9 to pelvis with the decompression at the L1-2 level with a corpectomy, and then vertebral augmentation with transverse process hooks. And then we also, you can see here, we augmented the UIV and then as well as our screws at L2 and L3. Here was our correction on CT scan postoperatively. Excellent local correction with the corpectomy and decompression. Here you can see standing x-rays, good bicortical purchase on the pelvic screws. Here is, I believe this is at 3 months, patient's upright walking with a brace. And then you can see here just some stable settling radiographic PJK at that level, about 15 to 20 degrees. Patient is ambulating with a walker and has had an improvement in their ODI of 35 points already at 6 months. They were using it. So they're ambulating upright, saying that they don't have back pain. And neurologically intact.
Dr. Hart, you've published extensively on major spine surgery and proximal junctional failures, et cetera. Were we insane to do surgery? Obviously, did we get lucky here? What are your thoughts?
Well, I wouldn't say insane. This is, it's a lot of surgery for somebody with this health status, bone status for sure. I was going to weigh in a couple of things. I think the classification systems here are valid, but really the classification system doesn't tell you more than the anatomy of the fracture. And this anatomic pattern in someone with his health status, age, and bone density probably doesn't deserve maybe the same treatment as somebody that doesn't have those issues ongoing, right? So the classification systems don't necessarily incorporate some of these other features in clinical decision making, and that's not a criticism. It's just not what they're intended to do. I have written about and used vertebral augmentation. I like that technique. You did the 2 levels that I would do, which is UIV +1 and UIV. I did eventually kind of go away from that because I found that it maybe puts the intervening disc at risk. And the bigger thing is, I think that it doesn't protect the posterior column, which is what's happened here. So I'm much more likely to tether now than I am to augment, tether the posterior column. I think I do like the contour of the upper rods here, that those are contoured into kyphosis, and I believe it looks like we're kind of bent down into the fixation points, which is what I always try to do in my OR with the proximal junction. So for this particular patient, I might have tried just a laminectomy and kyphoplasty of the L1 level, maybe including a laminectomy of L4. I've done that in osteoporotic burst fractures. Clearly, this patient needed surgery, so nobody would argue with that. But I think it's an unsolved clinical problem with the technique I've described. I mean, I don't think her alignment is it a male or?
It's female.
Female. I don't think her alignment is really that much of an issue for her. It was really more the neurology. And so I think I would have just left her where she was alignment-wise, not done a fusion, augmented the burst fracture at least, and then just done a laminectomy elsewhere. And so far, I think I've done, I don't know, 15 or 20 of those. And so far as I'm aware, I've never had to revise a single one of them. And they all have provided some neurologic benefits. So I think this is a case where maybe less is more, and I certainly probably would have tried that before going to this extensive of a reconstruction, but I still would not call it crazy.
What about all posterior corpectomy versus the new lateral, quote, MIS or retropleural? Does anybody have their experience with elderly or more sick patients doing those lateral or MIS type corpectomies? Are they more difficult? Or do they not tolerate them as well as someone else?
No, I mean, I think that's a legitimate option. So you could stage it.
Dr. Ahmad, do you have your case ready to go?
Ahmad. Dr. Ahmad, are you ready?
Sir, I'm ready.
Yeah, let's try. If you have if we have a feedback problem here or a download problem, we may switch. We have one more case prepared, but let's see your case. We have about 10 minutes, okay? Dr. Ahmad, the podium is yours. Go ahead.
Okay, Ahmad, go ahead. Oh, yeah, Ahmad.
Otherwise, we have one more case prepared, but do we have a working presentation? Zach, we may have to switch to your case. Can you double click this icon? Otherwise, we'll switch and we'll preload it for the next time. We can reschedule for next time otherwise. Let's see. One more. Okay. Okay, let's do the following thing, Dr. Ahmad. We'll reschedule you on a priorities cases for the next time. And
I just can start now.
No, we need the pictures also. Can the slides be shown? Let's try one more time. If you can't show the slides, we'll ask you to download it for the next time, okay? So hit the slides one more time, see whether you can make it appear. Otherwise, we'll have to move on. So I can see you, but somehow we can't see your slides. Okay, all right.
Nadeem, can you share my slides, please?
Yes, I share. Okay, you can start. Yeah, you can start. Yeah, okay.
All right, let's go.
So,
Mahmood, start.
So my topic is fungal spondylodiscitis. Actually, maybe a challenge in certain cases, as we are not suspecting that the infection is right there in our region. Actually, the tuberculosis is much more common than any other kind of the infection. So in the case, literature showed that it's spondylitis or the spondylodiscitis. In the 60% of the cases, it's actually the pyogenic infection, and then non-pyogenic infection, it may be fungus or the bacterium, mycobacterium tuberculosis. Among the mycobacterium tuberculosis is almost forms more than 30%. In our region, it's almost more than 70 to 80% cases of the spondylodiscitis or the spondylitis. It may be in the form of the tuberculosis. In the immunocompromised patient as well as in the immunocompetent patients, fungal spondylodiscitis have been found. Next slide, please. So the fungal spondylodiscitis, it is difficult to identify by cultures because of its slow growth, and so histopathology always helps in identifying such organisms. Actually, in my case also, the first evidence of the fungal growth was the histopathology. It was not on the culture. Next slide, please. So my case is it's 35 years old male, belongs to remote area of the Punjab. It represented to me in the July, 24 July, along with the complaint of the back pain and the difficulty in walking from the last 7 months. There was history of fever and weight loss also. Ultrasound, previous ultrasound showed a gluteal abscess, and insane drainage was done for that in the late of June. In that patient. Patient was actually taking ATT for its TB spine, which was diagnosed, but not it was empirically ATT was started. Patient was also happy, positive, and treatment. He has also taken treatment for that also years back. There was no comorbids actually at that time. Next slide, please. Clinical examination showed GCS was 15/15, and along with the power in the upper limbs was normal, but in the limbs it was 4/5 in the right side. On the left it was, and reflexes were diminished. Bowel and bladder was normal at that time, and on the CS was 90 with normal renal parameters. Next slide, please. X-ray and images was suggested. Next slide. In this MRI here, you can see that L4 area and L34 and L45 area, actually it is much more disturbed. On the two weighted images, we can see that there is trends of the increased, there is a increase of enhancement in the L4 vertebral body as well. L3-4 disc as well as the L4-5 disc along with the body was involved in this case. So we were planning along with it, there is cutoff. Next slide, please. There is cutoff. You can see cutoff line at the affected level, L4-5 level. Actually, in this slide, you can see that there is increased enhancement at the L4 vertebral body along with L3-4 disc and L4-5 disc as well. So we were thinking about that whether we should go for the discectomy along soft T-leaf or in the form of complete radical debridement in the form of mesh cage and screw fixation. Next slide, please. So the same cases in the T1 images.
All right. Yeah, carry on. You're breaking up right now. Please continue. We have a problem with your voice. Yeah, continue. Okay. So screw fixation was performed. We can't hear you right now. And a soft T-lift, so local bone graft is applied, gluteal incision, okay. And carry on to the next slide. I'm sorry, we can't hear you right now. So can you go on to the next?
Can you hear me?
Now I can hear you, yes.
So soft T-leaf was done, L3-4 level, L3-4 and L4-5 level was done. And we did not go for the radical debridement when I was going for the pedicle screw fixation. I was making the holes in the pedicle. There was no pus from the body, and there was no purulent discharge or other thing like that. So I confined myself to the fixation along with the soft T-leaf, and biopsy sample was sent. This is the post-op X-rays, post-op. Next. So the surgical findings were there was spondylolischitis, there was no pus from any pedicle, there was decreased purchase of the bones overall, there was osteoporosis. The specimen was obtained from the disc space, and this was not typical of the tuberculosis. Next slide, please.
All right.
There was no growth. There was no granuloma or malignancy, or fungal cultures were suggested in that case. Actually, in my case, I did not send the fungal cultures. In the initial scenario, I sent the cultures for as per routine, and also the TB gene and other things, but I could not be able to send the fungal cultures as a separate entity. Next slide, please.
All right, keep going. Go ahead, next slide. You're breaking up again. And keep going. Yeah, we don't need to see the slide. Keep going, please.
So next slide, please.
Yeah.
Next slide, please. So anti-tuberculosis treatment, it was continued as patient was taking already. As in our area, the tuberculosis is an endemic disease. So we did not stop it as at that time. ATT was continued. Along with that, antifungal therapy in the form of the diflucan was also started. We were keeping empirically started. We tried to empirically start the amphotericin B, but it was not available. Liposomal type was not available, and the amphotericin B other type, which is formally available in the market, it is highly hepatotoxic, and so we go for the diflucan only. Patient was advised weekly follow-ups, but patient developed worsening of the symptoms along with the cauda equina symptoms, with difficulty in the walking, with the numbness of the legs and numbness of the perineal region, constipation with forceful evacuation, and difficulty in passing the urine. So it was full-blown case of the cauda equina recurrence of the symptoms again. So we were again, the Rivian MRI show again, there was low-grade spondylodiscitis at the same level with the epidural phlegmon, also with the central canal stenosis, which along with the cut. Next slide, please. On the MRI, you can appreciate that there is a complete cutoff of the myelogram, and there is also you can appreciate some sort of the phlegmon also. at the level of L3 for vertebral body. Next slide, please. So the revision surgery was planned. And we go for the decompression again. There was the fungal growth. It was encircling almost all around the cord. It was removed. All the fungal tissue or the phlegmon which can be removed was removed at that time. Along with there was almost 2 liters of the blood have been lost during this procedure. So we have to minimize the procedure up to that, and we place the graft again, and we send the fungal growth cultures this time, and we close. And histopathology, next slide, please. Histopathology revealed fungal spondylodiscitis, culture revealed Aspergillus fumigatus, and treatment, and it was sensitive to the amphotericin B. Next slide, please. So as per culture, amphotericin B was started, medication started, but on the 8th day of patient developed hepatotoxicity and bleeding from the wound. Ultrasound revealed cirrhosis of the liver with the bilirubin reaching up to the level of 10. So we were at nowhere again. We have re-explored the patient, but again, we were we were in a blind alley. Next slide, please. So with the bilirubin 10, with the normal AST, LT levels, with the ultrasound revealing the cirrhosis, amphotericin B, and all sort of the antifungals were stopped, and patient was referred to the gastroenterologist. After the resolution of the jaundice, patient was referred to the infectious disease specialist. Next slide, please. So on the first visit, there was they were suspecting that there is cirrhosis of the liver due to the hepatitis B. So they started medication as per that, and they just planned for, next slide, please. They planned for the CT lumbar spine with the IV contrast as the CBC, and the creatinine levels were normal, and next follow-up was advised. Next slide, please. As per CT, here we can see that the pedicle screw is dislodged from the L4 vertebra. The pedicle screws are at their normal side, but the pedicle screw of the L4 was dislodged out due to the infective tissue, and also you can appreciate that there is a lacunae, or there is no bone in the intervertebral disc area. Along with there is sequestra also present in right there. So along with there was phlegmon also in the central canal. Next slide, please. Next slide. In the report, there was phlegmon present in the central canal, which was compressing the cord. So the features were the fungal growth was increasing over the time. The first surgery was done on at the end of the July, and it was December, and we were still on the same side with the fungal growth, which we were nowhere to deal with that. We have started diflocan, we have started amphotericin B, but again we have to stop. But now the hepatitis B was also reactivated, so voriconazole was started for the fungal treatment, and antisavir was started for the hepatitis B. So the combined treatment, the regime was started, and CT was planned in the last month, and on the 8th March of the last month. Next slide, please.
Okay, we'll have to come to a conclusion, Dr. Ahmad. Yeah, we see the slide.
I'm left with only 2 to 3 slides only. So the voriconazole was given along with the antisavir, and the patient was, next slide. So the fungal growth is now resolving. Patient is normal with the normal bowel and the bladders. There is patient having the weakness of the legs at the area of the L4 and L5 area, but the back pain has been abolished, and along with that, there is bowel and bladders have been now normal again. There is evacuation for, there is normal, patient is passing the stools and urine normally now. Next slide, please. So it is the CT of the next slide, please. Next. It is the last report, which is showing that there is no residual infection or residual any collection. But we have continued. Next slide, please. Next slide, please. So we have now at that time voriconazole have to make all this mess have been we have it has been resolved. So right now the patient is with the normal bowel and the bladder, with having the weakness of the legs as well. But now there is no backache, and hopefully in the next 3 months, patient will be improve much more. So take home message is atypical spinal infections are difficult to diagnose and difficult to treat as well. Complete serological and radiological workup should be done before any sort of the intervention, and always keep diagnosis broad, and every tissue should be sent for the histopathology, culture, and sensitivity gene expert for the tuberculosis and fungal cultures as well, which we have learned it has been advocated by our seniors, but there was this bit lacking, and which is resulted in a disaster. Next slide, please. So always anticipate any issue before it turned out to be a disaster, and multidisciplinary approach is mandatory for smooth sailing. In all this scenario, I took help from my seniors, I took help from the gastroenterologist, I took help from the infectious disease specialist. So it's in such cases, there is smooth sailing is never ever possible without a multidisciplinary approach. Thank you very much, sir. Thank you.
Thank you, Dr. Ahmad. Nice job. Again, we'll switch to Dr. Ishak. I think I urge you and your colleagues, friends in Pakistan, to collect cases of atypical infections as much as you can and help us all understand how to better appreciate them with early laboratory investigations and targeted imaging and antimicrobial therapies. I think that's a very valuable insight. And again, this case shows how we always have to be prepared for the unexpected. So we can't discuss more in detail, but thank you for this contribution. And
thank you. Do that. We'll collect the cases. Yeah. Thank you.
Please collect them. Okay, thank you.
Thank you.
We're switching back to Heidelberg, Germany, the beautiful city of Heidelberg, Germany, with Professor Basem Ishak. He's the chief of spine surgery at the very well-known and highly regarded University of Heidelberg, one of the oldest universities, I think, in Germany, if not in Europe. And he was a fellow here a couple of years ago, but he trained in Munich, Germany in spine fellowship. He did his neurosurgery training and graduated in March 2017. In a rapid time, he's become one of the most prominent spine surgeons in Germany. He is administratively engaged in the Deutsche Wirbelsäulengesellschaft, the German Spine Society. He is a AO Spine Global Diploma faculty carrier in Europe, Africa, and Middle East, and he's a deputy editor in the Global Spine Journal. He has always had a great interest in looking into particularly challenging and difficult scenarios, and today is no different. He's looked and stormed headfirst into the question of, is there an age limit for complex spine surgery? Baz, it's great to have you with us. Thank you for your comments in the cases earlier. We're very much looking forward to hearing your insights from your investigations.
Yeah, thank you, Dr. Chapman, for this very kind introduction, and greetings to all of you who are sitting in Seattle. I hope you see my slides. I hope everything works fine.
Yes, they come across great, and your voice and picture sounds great as well.
Awesome. So here again, my disclosures, not very much. So is there a limit for complex spine surgery in the elderly? And the question arises, why? Why is it important? I mean, why do we think of treating conservatively or surgically? And if we do surgery, how invasive should surgery be in this very elderly adults? So we know many of those patients have comorbidities, and not only comorbidities, also severe comorbidities, which might influence the surgery itself. We often have to deal with poor bone quality. We had this in the discussions today. This is always a huge, huge deal. And we have a decreased cardiopulmonary reserve. So even little blood loss might be significant and can cause hypertonia and stress in the OR. And actually, I experienced that a couple of weeks ago. And of course, complications which might be associated with the comorbidities and the challenging surgical treatment strategies. So we know from the literature and we know from statistics that the age demographics is projected to change dramatically within the next 4 decades. And the percentage of citizens older than 65 years is predicted to rise to 28%. And the percentage over 80s, if we look deeper to that, will increase from 5 to 12%. And The other thing is that the patients, even the very elderly patients, have an increased demand for spinal surgery to achieve a higher quality of life. We have very elderly patients who love skydiving or other extreme sports. We have patients who want to be active even in their 80s and probably sometimes in their 90s. And we have elderly patients we see every day in a fitness course. And actually, this guy is better in shape than me.
That's hard to imagine. You're pretty stacked.
I know, but I've seen this with my own eyes, right? So I try to work on that. So I would like to start with the most common traumatic cervical fracture in the elderly. It's the type 2 odontoid fracture. I mean, there is no doubt, if we see the left image, the sagittal CT scan, it's not dislocated, the patient has a bit of neck pain, and we say the transverse atlantic ligament is intact when we do coronal views. And of course, this patient can be treated conservatively, but this is not our daily business. It's like that. And the same we've seen before with the ex-spondy patients. We have a highly unstable odontoid type 2 fracture with dislocation. And of course, the surgery, I mean, we have several techniques and so on, but it's still dangerous and a complex, very complex surgery, right, to treat those fractures, even if it looks nice in the images. And if we think we can treat this conservatively with a rigid collar, for instance, we know exactly what will happen months later. We have further displacement, we have probably a neurological impairment. And of course, someone can say, okay, why are you using rigid collars? How about a hollow vest? And we know nowadays that hollow vest immobilization is a death sentence. I mean, we have a probably high non-union rate. We have issues with the pins. We have probably to do adjustments of the fixation after a couple of days. And we've seen a high rate of cardiac and pulmonary mortality. Right. So this is something we do not use anymore here in Heidelberg. I mean, we had in the past one patient who said, I don't want to have surgery at all. Please give me a hollow vest. And we say, we don't do that. We referred him to another department, and then they put a hollow vest on his head. And the same day he discharged himself home and removed the vest. Right. It's difficult to tolerate for 3 months. So, and therefore we stopped doing conservatively, especially in dislocated fractures, because the non-union rate is 100%, right? So, and this is what we did in 2016 and 2017. We started to say, okay, let's do surgery and let's favorize surgery in the very elderly, which means over 80 years of age, and modify the screw technique. This is the so-called posterior arc lateral mass screw. Dr. Chapman loved this screw, and actually he probably developed this technique before we did, but we published on that. What we did is just to modify the screw just to the posterior arc beneath the vertebral artery. If you put a Penfield hole inside, nothing happens. And the problem is, if you do the classic entry point, what Dr. Skuyan loves to do, you have to deal with the epidural venous plexus. If we, on the other hand, ask our friend Dr. Rick Sessel from the Indiana Spine Group, he says almost no bleeding. He opens up the plexus and no bleeding. And I truly believe in that, but I have never done that and cannot do that. Several times I tried to do that, but often a lot of bleeding occurred and the patient became unstable and hypotonia. So we have several results by modifying the C1 screw through the posterior arc. And we did this in 35 patients. And what we had was also a follow-up from 6 to 72 months, not only with clinical and radiological outcome, but also with functional outcome using the SF36 survey and using the Eurocall quality of life index. So if we analyze our cohort of 35 patients, we haven't seen any intraoperative complications. All screws were placed correctly. We verified that using our IOP CT. Hospital stay was 14 days, like almost 2 weeks, 2 days ICU stay. So all of these elderly patients undergoing complex spine surgery should go at least for 1 night to the ICU. We had no in-hospital or procedure-related mortality. And the overall major complication rate was 11%. And we also looked, which is like an intermediate term follow-up, and up to 72 months, is that we contacted the families and practitioners to see what happened to the patients. And 5 patients died with a median time to death of 30 months. This was not related to the surgery. It was due to a stroke, cardiac arrest, pulmonary embolism, and tumor. Because we had this good results with over 80s, we said, okay, when the patients getting elder, we have a global trend in increasing life expectancy. We have accelerating improvements in the quality of healthcare. So how about patients over 90? So we exclusively looked at patients over 90 years of age with a follow-up of 3 years. We could include 15 patients. It's not much, but we don't see those patients very often. And did the same. I mean, on the left side, you see a dislocated odontal tattoo fracture. I mean, this patient had no neurologic impairment. Then we did reposition in the OR manually without electrophysiology. And Dr. Chapman will surely catch up on that later on. And on the right, you see a postoperative image. And you also see that, like, the vertebral artery, the sulcus, is very close to the C1 screw. And if we look at this 15 patients with a mean average follow-up of 3 years, we've seen like one C2 screw was penetrating the transverse foramen slightly with no problems after we did a CT angiography. We haven't seen any in-hospital mortalities. The length of hospital stay was almost 2 weeks with an ICU stay of 2 days. And while catching up those patients over years, we've seen like 1/3 of these patients died with an average time to death of 26 months. And if we look further for the complications, we've seen a minor complication rate of 27%, including UTI, delirium, and this one is screw misplacement. And one patient developed pneumonic sepsis during his hospital stay. So we have seen clinical results, we've seen radiological outcome, but are there any predictors? Is there something we probably have missed in the past or we haven't looked at exactly? So, and this was the idea to start this study by looking for radiological features, radiological patterns in patients with type 2 odontal fractures after high and low energy trauma. Right, and these are also elderly patients. Elderly was defined as patients over 65 years and older, and this is the standard definition for that term. And we did all the measurements required from C0, C1, C1, C2, angle, the C1, C7, SVA, C2, C7, SVA, McGregor line, Chamberlain line, McRae line, right? And we looked for special features, and we defined high impact or high energy trauma according to the German Orthopedic Society, which means car accident with over 80 miles, hit by bus, hit by truck, falling over 5 steps, right? Or falling over 1 meter from a tree, for example. And low impact means like falling from a sitting height or standing position beneath 1 meter, which is equivalent to 3.2 feet. And if we look for osteoporotic patterns and osteoarthritis, we've seen at the junction that we've seen in the low energy trauma group a significantly higher rate of patients with severe and moderate osteoporosis, right? And we also looked at the atlanto-odontoid joint, where we've also seen higher rates of degeneration, osteophytes, and ankylosed joints. If we look for the measurements, what we see on the left side, and I just want to catch up on the significant ones, we've seen a higher anterior atlantodental interval, higher ADI, a higher C0, C2, C1, C2 low doses. And what we've seen is a C2 to C7 SVA, which was significantly higher in the low energy trauma group. We have now the radiological results. We have the clinical results. We have the functional outcome. We have quality of life. We have the radiographic patterns. So we said, okay, what could also be related to an increase of odontoid fractures in the elderly? So we catched up with the anatomical model we did with the great resources of SSF, and I can't say that enough. We tried to figure out a more physiologic anatomical model, because we catched up the literature and we've seen that this was updated, 30 years ago, and the testing, the colleagues, which were mainly influenced by Punjabi and Dvorak, had nothing to do with anatomical settings, right? So we dissected, we harvested 12 C1, C2 specimens. We only left the transverse ligament intact, keeping the bony structures, removed all soft tissue, and we tried to pull the dents axially against the transverse ligament, just to mimic a physiological situation. And this looks like that. We fixed the dents with a clamp and then fixed the anterior arc of T1 with clamps, and then we pulled axially with a tensile strength testing machine the dents against the ligament, and we measured the Newton which were required to rupture the ligament. And the mean age was 81 years in those specimens. So we have those elderly cohorts, and the mean failure force of the transverse ligament was 236 Newton. And this was 100 Newton below what has been known previously from a study done by Dvorak in 1988 with 350, in Punjabi 367, right? And if you look at the limitations of all those studies, you not only see differences in failure forces, but you also see like all ligaments were left intact, bony structures removed, dents was replaced with a steel rod, and ligaments were tested twice, right? And we tried to be a little bit better and try to mimic ideal physiological situation in an anatomical setting. And because we were talking later on about this case with this elderly guy having multi-level cervical spondylotic patterns with myelopathy, and we were deciding what are we doing, just anterior, posterior, or a combined procedure. And what we did was to look for what's the difference between a single-stage combined anterior and posterior to a posterior only decompression infusion crossing the cervico-thoracic junction. And we actually could include 14 patients with a single-stage combined anterior and posterior, and 12 with a posterior only. So these patients are very rare. So on the left side, you see this combined procedure where you get great lordosis or improvement of the kyphosis, and on the right side, we see that it has been corrected a bit, but we still have a deformity and a kyphosis, right? And if we look at the results, the AP group is the anterior and posterior single-stage group compared to the posterior-only group. We've seen that even the blood loss was not significant, but the surgical time was significant. And this is, of course, if you flip the patients and do again anterior approach, this costs time, but we all knew that, right? But which is more interesting is that we definitely could correct those patients significantly better, especially the C2, C7 cup angle and the T1 slope. I mean, this is the idea of a combined procedure, not only decompress anterior and posterior, but also align this patient, right? So we had good images, but the question is, images are not enough. It's more time. It could be more invasive. The patients are very sick. They are very old. So is it enough to just do a posterior only, or should we focus on alignment and sagittal balance? And if we look in terms of complications, and I just want to focus on major complications, we see in this 12 patients which were included in a single-stage anterior posterior surgery, had 1/3 needed a peg replacement because they had swallowing issues, right? I mean, if we look to the minor complications, even in patients who did not have an anterior approach, had some dysphagia, right? So we had a high rate of dysphagia in both groups, right? But probably if you do a approach, and this included at least 2 or 3 levels anterior fusion, you somehow have this problem in the elderly, that they have some swallowing issues. I mean, probably there is minor innervation of the muscles, or we don't know exactly what's going on, but they have some swallowing issues. And 1/3 of those patients who underwent a combined anterior and posterior approach received a pec tube placement, right? So therefore, we just can say that alignment should be weighed against potential complications. This is not bad to do that. This is it's also good, right? So the surgeon has to decide, right? And then another study, and this is about ankylosing spondylitis, and we were featured with that last year in October in JNS, is where we look at the rates of early complications and mortality in patients older than 80 years of age who underwent surgical treatment for ankylosing spondylitis and compared the results to osteoporosis. And you see on this image, we have a highly unstable osteoporotic fracture at the thoracolumbar junction. We just focused on thoracolumbar because we know we have sometimes combined fractures, cervical and thoracolumbar, but to make it publishable, we just focused on thoracolumbar fractures. And again, this is just a shortcut of this study where we included 22 patients with AS and compared it to a group of 24 patients with unstable osteoporotic fractures. And we always say less is more, but in ankylosing spondylitis, there's no deal. You have to fix them and not 2 above, at least 3 above and below. And if there's a gap, that's fine, right? Because you have a high lever at that index level. And if we look at the demographic parameters, this is what we said before. We have patients with a high Charleston comorbidity index, so very sick patients. And if we subdivide the Charleston comorbidity index, we see that cardiac disease was most common or more common in the ankylosing spondylitis group with almost 64%. So 2/3 of the patients had some cardiac issues. And we heard before that this patient with odontoid fracture and ankylosing spondylitis had some heart valve issues. So this fits perfectly to what we found. And if we look at the 90-day complication profile and we just focus on the major complication rate, we've seen a significantly higher major complication in the ankylosing spondylitis group, including respiratory failure, myocardial infarction, renal failure. But what we often see, and this is well known in patients with ankylosing spondylitis, is that they had some gastrointestinal bleeding and bowel perforation, right? And we actually learned from the study, because if we ask surgeons who do surgery, like emergency surgery in those patients, they say we often see some kind of inflammation in those patients, and we often diagnose Crohn's disease or colitis ulcerosa in those patients, what they did not know many decades before. And if we look for the clinical course, a higher ICU stay with almost 4 days compared to 1.3 days in the osteoporosis group. And what we've seen is in-hospital mortality rate below 10%, which is even less than published in most studies, not addressing very elderly, but elderly patients. But we've seen also that 90-day mortality rate was 36% in patients with ankylosing spondylitis. So even after discharge from hospital, something happened. So the patients were doing good, they were doing great, pain was fine, complications could be resolved conservatively, but 36% had some issues like bowel perforation or sepsis. And this is just one patient just to show what happened. This patient was like doing very well. So, and then he had some inguinal pain, and this left abdominal X-ray revealed free air in his abdomen. And if we look for the CT scan, we see this incarcerated hernia in his right inguinal area, and we see also air here in his abdomen and here. So this patient underwent emergency surgery the same day after diagnosing this. Emergency laparotomy, they addressed and they assessed the bowels histopathologically, and they revealed Crohn's disease, and the patient did not know about that for 80 years, right? But this patient died within a couple of days due to a severe sepsis, for example. In summary, if we look for ankylosing spondylitis, we have high complication rates in those patients older than 80 years of age. But despite this high morbidity and mortality rate, we still recommend surgery. I mean, even for non-displaced fractures, and even for patients who do not have any neurological impairment. But, and here comes the but, the risk should be clearly discussed with the patients and relatives. So we can conclude, this speaks for me. I can recommend, and this is what works for me. There is no age limit in complex spine surgery. If we want to answer the question we asked at the beginning, the complication when balanced against potential benefits, right? Careful attention to the patient's comorbidities should be taken into account, right? So cardiac checkup, everything what is necessary should be done. And a coordination with the anesthesiologist is essential. So thank you very much for your attention, and I'm happy to hear some questions.
Great stuff. Seriously, amazing. Just focus on a really relevant topic from so many angles: biomechanics, radiology, and clinical experience. Again, hats off, for instance, on your biomechanics project, which single-handedly kind of changed how we perceive ligamentous structures. Having personally previously failed in biomechanical experiments in this area, I really want to applaud you for that. Here's my question. So you addressed a lot of important issues. As a neurosurgeon, how do you address the issue of cognitive function of patients? We have so many patients with very varied cognitive functions. Where do we draw the line of just saying, okay, we'll give you palliative care versus, okay, you're good enough to try to give you a hope for surgery?
Yeah, great question. Always difficult to answer. I mean, a patient with severe cognitive dysfunctions and probably diagnosis of tumor, we probably would discuss this with the relatives together, because if the patient has cognitive dysfunction, it's not possible to discuss that with him in over 90s, for example, but we discuss it extensively with the relatives. And we tell them that these are dangerous surgeries. Surgeries might be associated with a high major complication rate, depends on if the patients had also severe diagnosis in the past. But we sometimes draw the line and say, okay, there's nothing to win, like for the patient, right? And it's just dangerous. But we discuss it extensively with the relatives, and this is how we do it.
I'm going to ask my partner, Dr. Hart, who's published a famous quoted study on ignoring odontoid fractures in elderly patients with good outcomes, to comment on your thoughts of that surgery offers better outcomes.
Yes, well, that paper, I think, still sticks in Dr. Chapman's craw all these years on, but it's one that I certainly hear about regularly. So that paper was actually about patients that present with a non-union. So this was a non-diagnosed at the time of injury, and then months to years on, stable without neurologic impact. And it seemed as though you could continue to follow those patients most often without them developing myelopathy. But of course, we know some of them do, and I don't think we really have very good predictors. I'm struck, Basem. Great to see you. I love the last slide, the lovely photo of your city of Heidelberg. Of course, one of the few cities in Germany that was not bombed severely during the war, and so a wonderful, continued treasure for the people of Germany and for everybody who lives there. I'm struck by your mortality rate of the osteoporotic spine patients and the Dens fracture patients. And I think most of these mortalities are unrelated to the procedures you're doing. And it reminds me of the data for hip fracture in elderly patients, which is pretty similar. By the time you look a year out, the mortality rate is somewhere between 1/3 and 50%. And we actually published a big database review of elderly spinal cord injury patients, or spinal fracture patients in general, and saw very similar results. And so I think a lot of these patients, these injuries, really are hallmarks of frailty, right? So they really are demonstrating that these are patients that are in some sort of an end-of-life pattern, and this is just part of what that pattern looks like, really. And I certainly agree. These patients that have neurologic vulnerability, or especially neurologic symptoms, really, we don't always have the option of not intervening. So really the challenge is figuring out how we can safely and effectively intervene. And as I said earlier in the program, I think it's still somewhat of an unsolved problem in some of these patients because standard implants may or may not hold. Standard techniques may be just too much for what the patient can withstand. And yet there's a need still to figure out how to protect them neurologically down the last months of their lives.
Yeah, thanks, Bob. Great to see you too.
1 second, we have Dr. Molinari asking a question. I'm going to try to flash that up. Thank you, Bob, for viewing us. So Dr. Molinari agrees with Dr. Hart. I was expecting a caustic statement by him. One of the key things that I want to ask you, Baz, is how does the approach work for you for a type 2 odontoid fraction elderly patient to put them in a rigid collar and just sit them up, get an x-ray and see how they do? Can you just take a couple of days or even weeks to take a breather and see if they stay aligned and if they're comfortable, or is it important to act fast and decisively?
Yeah, thank you for this great question. I mean, if this fracture is not dislocated, the patient is very sick. So why not to give him a try in the rigid collar? I mean, if we do that, and we do that too, right? We do not do always surgery on those patients, maybe 95%. But we give him a try. We watch them for 2 weeks, 4 weeks, 8 weeks, 12 weeks. But if nothing really happened or we see further dislocation, and this is our experience, I can't remember that we've seen like even 2 patients in the past years where we put them in the rigid collar and the fracture stayed as it is, right? We have seen further dislocation and the patient complained of neck pain even after months. So we did that, but our experience was not good.
This is really valuable. We'll have a lot of additional viewers and questions, and we'll have to have you back again when you visit here. Want to thank you for your talks and all of our fellows and our colleagues in Lahore, Dr. Tariq Sohail and Dr. Ahmad, thank you. And many thought-provoking discussion points were had today. Want to ask you to join us May 4th for the next TED Talk coming from Curitiba, Brazil, talking about stem cell therapy for spinal cord injury, a very contentious subject again, with new hope hopefully applied. And have a great day. Stay safe, everybody. And thank you, Baz.
My pleasure.
Thank you. Bye.
Thank you. Thank you, everybody. Thank you, Ishak.
Thank you too.
Thank you.
Thank you, everyone. Nice to see you from all over the world.
Thank you, Ishak. Bye.
Great to see you. Greetings to Pakistan.
Dr. Mahmood. Thank you, Basem.
So. So, Linda, can you hear me?
Sure can.
I can. I sent an email that I will be in Seattle actually at the beginning in June after the Global Spine Congress.
Yes.
So if you want me to do any talks or whatever, just let me know. Right?
I think it turns out that the exact week you are here, there is not a single conference going on magically.
Oh, wow. Okay.
We usually have one, every week, but it happens to be an off week. So.
Oh, wow. Okay, good. No problem.
Okay, Linda, bye.